So, and now it's a, it's a big area for our hospital, vascular disease. So this is really a pleasure to hear somebody who's an expert in this field, and kind of share his insights and tips for the management of this complex condition, which I think we can all use. So without further ado, it's an absolute pleasure to introduce Dr. Kaadan. Good afternoon, everyone. Thank you very much for the opportunity to talk to you all about vascular medicine service, turning point in the vascular care. It's actually very, this topic, I mean, nothing to disclose in my presentation. So we'll start my talk with giving a background and history about vascular medicine in general. What is all field all about? I will give an overview about the training and certification, especially that we have residents here. So hopefully I get somebody recruited in this field as well, and we become colleagues one day. Next, I will move to the burden of the disease and why does it matter to have a vascular service in a hospital. And finally, I will talk about the conditions that we usually see and treat in the hospital. So a little bit of background, as I said, about the vascular medicine. It's relatively new field. The Society of Vascular Medicine and Biology was started by those 13 individuals. I'd say many of them are still alive and they are still practicing vascular medicine. Later, the society changed its name to become the Society of Vascular Medicine in 2007. So the goal of establishing this entity was to promote and advance the field of vascular medicine, to maintain standards of practice, research, and education about the vascular diseases, as well as to provide consultation to the institutes and agencies about the diseases in that field. So the initial decision or divisions was established was in the Mayo Clinic. That was the very beginning. And then we had one in Cleveland Clinic, Boston University, and Brigham and Women Hospital. And we have multiple training programs. Again, the first one was started in Mayo Clinic and then Cleveland Clinic. And I would mention something related to that. So I went to Mass General for my fellowship, and the one who established the program, his name is Michael Jaff. He was trained in Cleveland Clinic, and then he went to Boston to start the division of vascular medicine at Mass General. The reason I'm mentioning his story, because it's very much resonate with my story and with many people they got in the field. So after he finished his internal medicine training, he started cardiology fellowship, and then after a year he felt that he's not really into this kind of fellowship, and he decided to pursue a career and a training in vascular medicine. It was new at that time in Cleveland Clinic, thinking that he will start the fellowship and then he will go back to cardiology. But what happened, actually, he really enjoyed the vascular pathology, so he decided just to stick with that field, not going back to cardiology fellowship. And that's, again, it's very similar to my story. When I moved from Syria to Boston, I did my master's over there, but then I decided to do research, where I did my research in AFib, the relationship between AFib and cognitive impairment using functional MRI, trying to prove that those who have AFib more likely to develop cognitive impairment based on meta-analysis, but we wanted to prove that with functional MRI. I also did research in SCAD as well, thinking that after internal medicine, I would pursue my dream in becoming cardiologist. Then when I did my internal medicine residency at BMC, Boston Medical Center, I decided to apply to this fellowship to strengthen my application to cardiology fellowship. As you know, it's competitive as IMG, so I get, hopefully more interviews and then eventually get matched over there. And When I started the fellowship, I attended the TCT meeting. Many of the cardiologists here in the room, they know what's TCT. It's really eye-opening meeting. We had it back then in Boston. I think that was 2022. And then I attended the meeting. It's all about the interventions, interventional cardiology and the structural cardiology. So I was like, oh, wow, that's really interesting, eye-opening. So I really want to go to cardiology after finishing vascular medicine. And then, when the year went by, started to see more diseases get involved in it. I really like it, and I decided not to apply for cardiology. So that was like my story, how I ended up doing vascular medicine. Also, want to mention that most of the programs around the countries, it's 1-year program, except the one in Cleveland Clinic. It's 2 years. It's usually after your first specialty, either internal medicine or family medicine, mostly internal medicine, but very few programs, they recruit fellows after doing cardiology fellowship. That's a requirement in the application. For example, Brigham and Women is one of those programs. So back to Vascular Medicine Society, so they have their own journal. There are over 500 to 600 members worldwide who joined the Society of Vascular Medicine, including surgeons and podiatrists. It has annual scientific meeting. Next one is going to be in Philadelphia. For those who are interested, if you want to attend it, it's going to be next September, usually around September, October time. And then we do have state-of-the-art vascular medicine course for fellows. So I don't know, do we have a cardiology fellowship? Not yet, hopefully in the future. But even though if you're residents and interested in pursuing in the future for vascular medicine, you should apply to this course. It's over the weekend. It's get covered and sponsored for your flight ticket, for your accommodation. It's very interesting course. You're gonna learn a lot from it. And if you have any question, obviously feel free kind of to contact me so I can help you with the application and with the questions that you have. And then there are, as I said, more than 25 training programs worldwide. I would say it's more newer field, newish here in the US. In Europe, they had it already. Actually, it's more advanced, and the career or the field's called angiology, and it's very well established in some of the European countries, including Germany, France, and the UK as well. So that what we're actually hoping to get to that stage with the development in the field. Now, how does dedicated training make a difference? So the training gives unique set of skills in the vascular physical exam, the vascular lab, through the RPVI certification. So it's a lot of time we spend it during the fellowship is rotating in the vascular lab, learning about ultrasounds, ABI, and that's after having 200 or 300 cases, you submit application to sit for the exam RPVI, and that would allow you to read the images. And then after that, also there is broad differential diagnosis you can learn in vascular medicine, and I'm going to talk about some of the pathology that we see. It gives more familiarity with common and rare vascular diseases, familiarity with full spectrum of vascular laboratory tests, especially in the VTE patients, including PE and DVT, when you don't know why is this patient, young patients, didn't have really good compelling story to develop VTE. So big emphasis on learning about the hypercoagulable workup related to the VTE, and then interpret them, and based on that, know how to manage that. I would say Cleveland Clinic program has a specific interest in that. And since it's 2 years program, so big chunk of their time they spend in that particular area. Familiarity with reading and identifying pathology changes on images. So the expectation during the training, whenever you see pathology that does not make sense, or you need to make a decision related to that, and that was like almost all the cases when it comes to the pathology we saw at Mass General, because you get the very complicated cases. So the expectation is to go to radiology floor or radiology reading room and discuss those images with radiology, because again, a lot of time it's going to change your management between medical therapy or intervention. So that was a big part of the training. And there are obviously extensive international professional networks helps to extend our expertise and improve professional care. That's on the clinical level as well as the personal development level. So that there is really great resources for that, whether it's within the vascular medicine society or the community overall. So who goes, to vascular medicine? Again, it's MDs and DOs, NPs, PAs, with different backgrounds. You got internal medicine. I would say that's number one. And then you get cardiologists. A lot of cardiologists get interested in vascular medicine and they start to see whether they are general cardiology or interventionists, see vascular patients. You've got surgeons, IR, hematologists, nephrologists. I can't see the last one. I can't remember. So there is also a board exam. So after you finish the fellowship, you can sit for the board. And there are two types of boards, the vascular medicine one and then the interventional one. The intervention, so the vascular medicine, as I said, internal medicine. The interventional one, usually cardiologists after they finish their IC, intervention cardiology fellowship, and endovascular fellowship. So in our program at MGH, we were 4 fellows. I was the medicine one, and there were 3 interventionist ones who get treated in both vascular diseases, but less emphasis on that, but more emphasis on the peripheral interventions as well. So that's kind of about the board exam. I think it's froze. Okay, here we go. So we'll start with cases. I'm just going to come here. I will be able to see better if that's okay. All right, so we'll start with case number 1. This is a 36-year-old female with past medical history of back pain and C-section. She presented to the hospital with this leg swelling. Actually, I saw this case in the very first week during my fellowship. And, I just want to kind of make it more interactive for the students, for the residents. If you can just throw some differential diagnosis here, and we can kind of discuss them. Peripheral artery disease, one of them, DVT, exactly. I want to say that let's say if this is a chronic leg swelling, what would you think about? Lymphedema, exactly. And that's actually the diagnosis she got over time. And she was told kind of to live with it, do compression, all of that, physical therapist. But actually, her leg swelled to the point that she could not tolerate it. And that's why she presented to the hospital. So you guys gave really good differential diagnosis. So what she ended up having after we did this CAT scan, so you see this is the left common iliac vein that it's compressed between the right common iliac artery and then the spine, right? And that's what's causing this this leg swelling, which is what we call it May-Thurner syndrome. So May-Thurner, as I said, compression between the common iliac artery and the spine with the vein that causing this swelling. And there are 2 types of May-Thurner. There is May-Thurner anatomy. It's very prevalent in the population. You may find it up to 20 or 30% of the patients, but there is the syndrome. The difference when patients develop symptoms and develop DVT, the one that you mentioned, right? We call it a syndrome. So the way how we treated these patients, again, because it's very expensive, we did thrombolysis on her and they placed stents in the area so that would open this stenosis and prevent future clots in the future. We'll move to case number 2. This is 62-year-old man presented to clinic with calf pain after walking 2 blocks. He gets burning sensation in the back of his legs. This is worse going uphill and resolved completely after 30 seconds of rest. His past medical history: tobacco use disorder, hyperlipidemia, alcohol use disorder, hypertension. He works as a barber and he's most of the time on his feet all the day. His meds: aspirin, atorvastatin, and ibuprofen. His physical exam actually did not show any vascular abnormality. So the question for you guys, like, what is the differential diagnosis here, you think? What's that? Perfect. Sciatic pain. Claudication, meaning that arterial disease, peripheral artery disease. Anything else? Neurological, exactly. So that's exactly what you all said. So when we think about this patient, we categorize them in 3 categories: vascular, neurological, and MSK pain, right, from joints, very prevalent. But the point I want to make here is, if you have any doubt about peripheral artery disease, it's very important to screen those patients with ABI. And the reason for that, when you identify the disease and you control the risk factor, you're going to prevent the progression of the disease and the complication related to it. And that's mostly come from the cardiovascular diseases and the prevention of the events. When a patient has a vascular disease in their legs, in their extremities, that does not only mean it's only in the legs. It could be anywhere in the body. It could be, in the abdomen, neck, chest, heart, brain, all of that, okay? So that's the point that I wanted to make. Now, why does it matter to have vascular medicine and treat PAD? The reason for that, because the studies showed that there are around 200 million people are suffering from PAD. The average annual expenditure on those patients is 3 times higher than the ones who don't have PAD. And that's usually come from the direct cost related to PAD and the indirect cost from absenteeism, to the work and the care that the patients getting from their family members. Up to 15% of medical beneficiary patients develop chronic wounds, and that's cost around 32 billion related to the wounds comes from, the peripheral artery disease. 30 patients of the 30 patients of the population who are above 70, and 50%, who has history of diabetes and smoking reporting to have PAD. And that's really significant. So if you see 10 patients in your clinic, the majority unfortunately have hypertension, diabetes. Half of them, the one who are above 50%, they would have peripheral artery disease. Very prevalent, actually, more than what we think. And any age, given age, it's 2-fold more in African American compared to the white population. So there is a component of disparity, and I'll talk more about it. So how does the PAD present usually? The majority of patients are usually asymptomatic, no symptoms. They don't know that they have it, and you only find about it with your physical exam when you check the PD and DP arteries. Chronic symptoms, usually they complain about claudication. Most likely it's in the calf muscle with walking, right? It's improved with resting. It's similar to the angina, but the angina in the leg, in this. And they develop sometimes acute limb ischemia. And that's mostly from thrombosis, either, AFib, they throw emboli, or if they have endocarditis. So that's kind of the acute phase. And usually the one who take care of those cases, mostly vascular surgery or IR, depends to the hospital where they have the expertise. And lastly, the CLTI, critical limb threatening ischemia. And that's the one we want to avoid by treating the patients and putting them on the medical management. And usually those patients present with rest pain. They have pain at rest. The pain increases more when they elevate their legs because the blood goes against gravity, less blood flow goes to the foot, and improve when they put their leg down. That's very sensitive sign, as well as developing wounds that they are not going to heal. So our goal is to prevent those patients from reaching the CLTI. So what are the determinants of those patients who develop PAD? So there are different contributors, to the health disparities. I would say it's race and ethnicity. As I said, it's more prevalent in the African American, the Hispanic population. Geography, those who live in the rural area, they don't have access to healthcare. And there is structural racism or implicit bias. And here I want to mention, like, especially obese patients. Obese usually have multiple risk factors, and in multiple studies showed how doctors, they do implicit bias when it comes, to obese patients. They think that they're less likely to be compliant with these medications, and that's impact the patients show up in the clinic, and that's overall affecting negatively on their health. So we need to be aware about those stigma and biases among those population. And finally, the other social determinants of health, including the chronic stress, low quality of education. They don't show up to their clinic or discuss those symptoms with their primary care doctors. And because of that, you just don't know that it's related to peripheral artery disease, limited resources. They don't have the enough insurance to cover for the medications. And other poor access to healthcare when they live in remote area, etc. And then there are other risk factors. Older age, as I said, it increases when the patients get old, obviously, especially among those who are above 75. The patients with diabetes, because it affects the micro vessels, and that would make it very difficult for the wounds to heal in their foot. The smoking and other tobacco use disorder, chronic kidney disease, and that's important for two reasons. Number one, again, it affects the microvascular disease. Number two, it reduced the sensitivity of the ABI test. Those patients have more likely to have calcified vessels, and we will not be able to identify that on the ABI. So we need to pay extra attention about those patients. Number two, if the patients have also diabetes, their vessels may be calcified more likely. And number three, the one who are on prednisone would cause, more likely calcification on the vessels. And obviously, the patients have other vascular diseases, microvascular diseases, and also depression. They don't show up into their appointments. So when we reach the CLTI, critical limb threatening ischemia, we depend on multidisciplinary team that includes vascular medicine, vascular surgery, or IR. You've got the podiatrist, we've got pharmacy, and we've got the social worker who pay attention on those patients kind of to prevent the amputation. That's the main goal, actually. And we do that through revascularization, either endovascular or surgical or hybrid. Most of the time, especially if it's very well progressed disease, it's going to be hybrid. Wound care and management. It's very big part of it, pressure offloading. And then on some of the patients, we end up having amputation, but we have to do it as distally as possible, as you all know, and make sure that the patient's getting the treatment with the antiplatelets and the anticoagulation. So one thing changed in the new guidelines was published in 2024, this year, about the PAD. They moved the rivaroxaban 2.5 BID from class 2. Now it became class 1A indication to put those patients on rivaroxaban. The only caveat and the downside of it, it's expensive overall medication, but that became now a class 1A indication in any patients who you confirm peripheral artery disease and they are symptomatic. It would reduce the MACE and MALE, the cardiovascular events, and the limb events as well. So we'll move to case number 3, 82-year-old woman on apixaban for DVT found 4 months ago. she brought to the ED for long-term care, from long-term care facility after she had a fall. Obviously, she developed head bleed when you do CAT scan, especially after the fall, and she has an advanced Alzheimer's, so she fully depends on the staff over there to take care of her. And then you've got asked about what we do about the apixaban after obviously the acute phase. So let's say, you are on medicine consult, you get this question, this lady came to you, what would you do with the apixaban again after the acute phase? Was that? Stop it. Why? The bleeding. Let's say, we got rid of the bleeding after now 6 months. What would you do? Would you put her back on the anticoagulation or no? She had her DVT 4 months ago. Got you. That's a very good option. Exactly. All right. So what we do is usually the DVT treatment is 3 months. And she was on it 4 months, actually. So we hold it and we scan the leg. If she found to have a DVT, exactly, I would do the IVC. But if not, so we're done with the treatment. And the point that I want to make here is if the patient don't need the anticoagulation for extended periods, scan them, and you're going to see if they still have the DVT or no. So the other big entity in vascular medicine is treating VTEs. As I said, there are around 900,000 cases in the US, 10 million around the world. It's very prevalent. 20 to 50% of the patients who have proximal DVT, they will have post-thrombotic syndrome, which is, like swelling, wounds, venous insufficiency. So it's very high number. And the reason I'm mentioning these points, if you see a proximal disease in the common iliac, for example, call your IR. Is the IR do here the procedures? Call IR and discuss with them. Do those patients need procedure like thrombolysis or thrombectomy? And this question is important because you're going to protect them from this 20 to 50% post-thrombotic syndrome. And there are a lot of complications related to that. So that's kind of the take-home points from this. But you also don't want to undertreat them. I'm sorry, this is froze again. So you don't want to undertreat them, right? Or overtreat them. And it's expected we have around 250 ED visits related to the oral anticoagulation from bleeding. And half of those patients get admitted to the hospital. In fact, one ED visit for bleeding per 27 patients prescribed for the WAC that was found in 2020. And from what you see from this diagram, actually, we see this increase, a huge increase in anticoagulation presentation to the hospital or the bleeding related to it, similar to our patient I just described. So just give exactly what the patients need is very critical. And at the same time, you see, for example, the antibiotics related presentations going down. And this question is why? Because we have antibiotic stewardship programs. And that's why a lot of hospitals now and providers are advocating to have anticoagulation stewardship program in the hospital. That's not only is going to save the life of the patients, but also significantly reduce the cost on the healthcare system. So that's something we need to keep in mind. So hopefully we can have it in our hospitals. Now, let's say you got a patient, you were called about patients in the ED who developed PE. So how you're going to determine what I'm going to do for those patients? Because the treatment is either anticoagulation alone or anticoagulation plus intervention. So you refer to this guidelines, the European guidelines. If your patient is in the low risk category after you block the numbers, it's called SPC. You can find this test or calculator on MedCalc. You put it, if you see it's 0, then that's in the low risk, right? and you can put the patients on the anticoagulation. If you need to observe them in the hospital, fine, but if you want to discharge them, that's also fine. If it's positive, then you move to other markers. Do they have RV dilation? Do they have elevation in the troponin and their BNP or not? And that's where you make the decision about the intervention is needed. Now, this one, the high risk patients, when they're hemodynamically unstable, you gotta call the interventionist, IR, cardiology, whoever is taking care of the PE in your hospital. But most of the studies now, the clinical trials are here in this phase, in the intermediate. Nobody knows what to do with those patients when they are in the intermediate high risk PE. Anecdotally, what I saw actually from my experience, and again, it's different from case to another. If a patient who are like in their 30s, they developed a PE, but they have to go to work, it probably makes sense to intervene on those patients because they would go back to their work quickly or quicker than those who are only on anticoagulation alone, right? But if a patient who's like 70, 80 years old, right, you may put them on anticoagulation and you go away with that by monitoring them in the ICU. So that's why, the expertise here in the PE really matters to know what to do for those patients. Now we'll move to case 4. We have now 2 ultrasounds. If somebody can shout, what is the difference between image A and B? Good thoughts? Okay, so that's a little bit difficult. So we've got here DVT, but the first one is acute, and then the second one is chronic. And that's very good question. We usually get it to the vascular medicine consult. Do I treat chronic DVT? If it says, the answer to that, no, we don't need to treat chronic, right? How do we differentiate about acute between acute or chronic? So the acute, it's loosely attached to the wall. You see it with the ultrasound, it's moving, right? The chronic one, it's firmly attached to the wall. It's not moving. It's usually hypoechoic, acute, hyperchoic. It's more white. You see the hyperchoic, right, in the chronic. The vein itself in the acute, it's distended, but it's smaller in the chronic. It's spongy. You see it as a sponge, but it's more formed in the chronic. And then the collateralization, it's generally absent, but you see that similar to our patients. So you see some canals the patients developed to kind of move the blood along in the vein. And that's important to differentiate between those. Once you log into 300 cases, you can sit for the RPVI exam, the registered physician vascular interpreter, and you can sit for the exam. You will be able kind of to read those images as well. We'll move to case number 5. We've got this 45-year-old man with hypertension presented with sudden swelling, pain, redness in the left leg. For 2 days, Doppler ultrasound confirmed that there is a DVT in the femoral vein. You put the patients on Lovenox, and then you switched him to apixaban, and you discharge home. The patient's doing very well. Very typical story. We see that all the time in the emergency, right? But the patients presented after 2 weeks with increased pain and swelling, right? Although they say that they never missed any dose from the apixaban. So here you got to ask yourself why the patients, their DVT expanded, or at least it was not resolved. And then we did hypercoagulable workup, right? And we found that the patient has positive lupus antibody. So there is here a problem with the anticoagulation you put the patients on. So the question gonna be, what would you treat the patients with, right? You put them on Lovenox, you switch to apixaban, you discharged home, the patient came with more DVT now. What would you put them on? And they have lupus antibodies. Exactly. So you put them on warfarin. That's the drug of choice. So the patient was treated with warfarin. He got his INR between 2 to 3 gold. After 3 months, you do the ultrasound, and the DVT was resolved. Now, from this meta-analysis, actually, it showed you for those particular patients, comparing the one who got warfarin and those who are on the WAC, the one who are on the WAC more likely to develop arterial thrombosis, right? More likely to develop stroke, right? So the recommendation here you make is the warfarin is the drug of choice, and it does not impact the increase of bleed or the major bleed between the WAC and the warfarin. So what are the disorders that we treat in the vascular medicine? We treat, as I said, peripheral artery disease in the leg, and we treat the subclavian artery or vertebral artery stenosis. A lot of time you screen your patients for, I know, a mass in their lungs, and you get this read in the CAT scan that they do have a stenosis in the subclavian artery. So what would you do with those patients? Again, it's very similar to the PAD. You put them on aspirin, durvastatin, right? And one thing also you need to consider, it's more likely to be in the left side. So you need to do the blood pressure in the right side because it's going to give you a false low blood pressure if they do have this stenosis in the subclavian artery. We also treat carotid artery disease. Usually if those patients have stenosis below 70 and they are asymptomatic, no TIA, no stroke, you don't need to intervene on that, and you can only observe it with the ultrasound. And then you've got the chronic mesenteric stenosis, usually comes with postprandial pain, early satiety, nausea, weight loss. Very important. You scan the abdomen by ultrasound or do CAT scan and you see the stenosis. So you refer them to the interventionist either for angioplasty or stent, and then their symptoms resolve, or renal artery stenosis as well when they are on more than 3-4 blood pressure medication, including the diuretics, but their blood pressure is not very well controlled. VTE, as I said, it's very well a big component of it. DVT and PE, and then phlebitis as well, right? And then you see the varicose veins a lot in clinic, in the vascular medicine clinic. You see a lot of edema, leg swelling. So not only cardiology like that, what we think it's like heart failure, so they develop leg swelling or edema. There are like so many reasons why patients develop, leg swelling. And I want to mention one of them. It's the difference between lymphedema and lipedema, right? It's lipedema, you only see it in female, right? And it spares the foot. Nothing going on in the foot, right? Lymphedema, you see it in the men or women, right? But it includes the foot, right? All the time you see it here bilaterally, but you may see it bilaterally or unilaterally. So that's a big difference. The other important sign, it's called Strummer sign, that you can't punch the skin because the skin in the lymphedema, it's very thick. So that's kind of important sign. We'll finish with this slide. So what are other conditions we treat? Again, thrombosis, arterial, venous, hypercoagulable disorders. You get a lot of questions about those. Arterial disease, either if it's dissection, obviously it's chronic, right? Not acute, that's the surgeon job, right? And if they do have aortic intramural hematoma or aneurysms, other abnormal vascular findings on images, as I said, the vertebral artery stenosis and subclavian artery stenosis, aneurysms not only in the aortic, but you might see them in the carotid, in all vessels could be possible, in the iliacs, visceral, in the extremities, everywhere. Vasculitis, that another area you overlap with rheumatology as well, and you work hand by hand with them. Other genetic connective tissue like Ehlers-Danlos and all of those diseases. And then, May-Thurner, as we talked about, spider veins, varicose veins, lymphedema, lipedema, and then the FMD, fibromuscular dysplasia. You see that a lot in clinic. And finally, the thermal disorders, including Raynaud and other related diseases. So you see that a lot in the clinic. Thank you very much, and I'm open for questions. Thank you for your listening. Please go ahead.
I have a presenting coagulant patient. Probably won't take the because of monitoring issue. But which